Yeah, congratulations, everybody, for this meeting of the Indian Society of Hip and Knee Surgeons. This is a great day for all of us in different parts of the country. And a lot of good wishes to you all, those who are here, those who are not here and listening in, and to everybody concerned. May you all have a great time during these pujas and the Dhanasekara and over the whole country, all over the world. So let's start off the proceedings. We have Dr. Dipak will now take over and introduce Dr. Pradeep Bhosale to you. Of course, he needs no introduction. And
yeah, thank you, Dr. Indrajit. As you said, wishing you all a Vijayadashmi greetings to all our colleagues. We are privileged to have Dr. Vikram Shah, the Managing Trustee of the Ishks, and Dr. Indrajit Sardar, the current President of the Ishks, my colleague, Dr. Dhanasekara, myself, we are the Education Committee members. Our past President and a very senior member, Dr. Sharan Patil, is the next speaker. And along with them, Dr. Pachore and other senior faculties have joined. I have privilege to an honor to introduce senior faculty, Dr. Pradeep Bhosale, who was the ex-head of the department in the KM Hospital and GS Medical College, Mumbai. And after having worked in the academic institution with so many publications on his name, he is now a senior director at the Nanavati Max Super Specialty Hospital. Dr. Pradeep is a known faculty invited by the American Academy of Hip and Knee Surgeons recently also for his talk, and he has done a very pioneering work on number of subjects, especially the approaches, the tuberculosis, and many things related to hip surgeries. And he is going to speak on the bony fused hip conversion to THR. So on behalf of Dr. Vikram Shah, the Managing Trustee, President Dr. Indrajit, my colleague Dr. Raja, myself, and all the East Executive Board, I take this opportunity to thank both the speakers for sparing the time on this auspicious day of Vijayadashmi. And I request Pradeep to please start his talk. Thank you, Pradeep.
Thank you very much. And same wishes for Dasara, Vijayadashmi, whatever they say. So it's my great pleasure to be today here talking to you. So I'll share my experience. Thank you, Dr. Indrajit Sarkar. Thank you, Dr. Dipak Dave, and thank you, dear Dr. Vikram Shah. He has created a big record in the world. So it's great pleasure to be here. So I'll be sharing my experience on bony fused hip conversion to THR. So, you know, in India, ankylosing spondylitis is a very common. I think everybody must have seen bony fused young males. They have deformity in different positions. And with the ankylosing spondylitis, there's a very high risk of heterodophic ossification. Spine is also fused, so that's a added problem. Then there are surgical arthrodesis, old septic arthritis, and one more important thing is rheumatoid arthritis. We have some cases where there's a complete bony fusion. So these are some examples. Spine is also fused, and it adds to the spinopelvic issue is a major issue nowadays. So understanding is a complex thing, and in ankylosing spondylitis, it is for complex. So usually both hips are involved. Spine is fused in ankylosing spondylitis. Indications of mobility. So hip deformity, bilateral fusion is a very severe disability, and the results are very encouraging in ankylospine because the ankylosing spondylitis. So it strongly recommend. And if you don't do, they have other problems, limb length inequality and deformed spine. Excision arthroplasty is an old age, poorly option. You know, today's modern world, it has practically no role. It is a salvage option. Now, when you see with the fused hip, there are various issues. It is very important to understand all the issues for THR. First is the anesthesia problem. This occurs when there is ankylosing spondylitis, where the cervical spine is completely fused. So I'll come to each and every point and highlight the issues and how to resolve it. Then, when the spine hip is uh, uh, everything is exposure is a big challenge. So we'll come to that. Gluteal muscles are the most important part of the function after doing a THR. So that gives a dynamic balance and helps patient to ambulate and good walking and mobility. On mobile hip, infused hip, you need to do a neck resection. And there's a very high chance there's a splinting if it is osteotomy is not sharp.
Recording in progress.
So preoperative planning is very important. You must understand all these issues and you should be confident to overcome all these problems. So restoration of the true acetabulum center of rotation, biomechanics, pelvic obliquity, spinopelvic issues, inclination, version, bone quality, length. Now let's come to anesthesia. Now when the cervical spine is fused, the general anesthesia through our conventional approach is very but we have done 100 and the spine were fused and our anesthetist could achieve spinal and epidural anesthesia safely because even in bony fused hips, whether there's a trabecular continuum, bony vertebra are completely fused, the facets are fused, but there's a triangle of ligamentum flavum between the laminae, and that is never fused. So this is our invention, and that triangle is available for safe spinal or epidural injection. It takes some time because the triangle is very small and you have to make triangle, but it's possible to do spinal and epidural. Second thing is conventional is when the spine is fused, modern anesthetists they use a endoscopic transnasal or under scope, they put the tube and that's also equally safe. So these are the various options. We have used both the options. And you have to rectangle, but it's possible to endoscopic is a very safe procedure and they know it how to put the tube in the trachea. There is no need of tracheostomy in modern world. Now approaches are plenty of approaches. You can go front, back. I have used all the time posterior approach and I'm very happy and I'll share my experience. Now, most important is spine is fused. Many times there are deformities, bilateral. So one most important part is when you do posterior approach, the patient is in abdomen. People putting servants, they put the position. Important that surgeon should take very special care the sacrum posteriorly. Very important
Recording
so
in
that
progress.
once you understand how much inclination is there, that will guide you to put your cup correctly. There's no need of prophylactic osteotomy. I have worked in Brightington, and they are very fond of. Overall, everywhere, I think trochanteric osteotomy is going off the practice, and it is not required, So in severe complete bony fused hip, uh, it is very important to preserve the muscles and avoid unnecessary trochanteric osteotomy, because you can do without that. Gluteal muscle function preservation is the most important. Now, even after 20 years of bony fusion, no movement, once you achieve mobility, the muscle function can slowly recover back over a period of time, because there's an intact nerve supply which prevents neuromuscular joint junction atrophy. Unlike nerve injury, if the nerve is cut, the neuromuscular junction gets completely destroyed within 6 months to 1 year. While here there are suboptimal, subfunctional impulses which keeps the neuromuscular junction alive. And once you achieve mobility, progressively the muscle function slowly returns back. Now, intraoperatively, color of the muscle is most important. There is no role of EMG, CT scan, or MRI for assessment of gluteal function. Clinical, you can see some palpation, intraoperatively see the color, and see the nerve supply is intact. Now, I have I have worked in anatomy department since I was a head of the unit and then head of the department. So, lot of patients initially used to come with external rotation deformity. Now, I am a posterior surgeon approach. So, whenever there is an external rotation deformity with bony fusion, anterior exposure is right in front of you. While posterior exposure, the trochanter goes very close to the acetabulum. Sciatic nerve is also very close to it, and it is very risky to expose also and to resect the neck, because the osteotomy or saw can go and enter the acetabulum and destroy the acetabulum. So there is a very high risk. So I have invented this approach for fused hip. I have worked in the cadaver, and last 32 years I've used this. So Bhosale's dual hip approach, anterior exposure in external rotation deformity is very safe, and the neck is right in front of you because of the external rotation. So same incision is used, retracted, and preserve the gluteus, anterior gluteus medius, which is spreads almost to cover up the hip. So put spike under the gluteus medius, anterior gluteus medius over the capsule, and one spike inferior to the capsule, expose the anterior capsule, which is very easy, like direct anterior approach, more easy because of the external rotation deformity. Then you cut the capsule and put spike under the capsule on the superior part of the neck, inferior part of the neck, as shown in the figure. And neck is directly in front of you for safe, easy resection with the saw. It's very safe. Once you cut the neck, you can cut a sandwich cut, and you get some mobility. Once you get mobility, then you go posteriorly, because posterior muscles are very tight and you have to release everything from the bone so that you get a good soft tissue balance. And I'm more oriented for posterior exposure. So I do my THR from posterior, but soft tissue release of the tight structure is absolutely important to achieve a good soft tissue balance. So one advantage with this approach is, even when I put a cup, I get opportunity to go front and back and check the impingement and alignment, because impingement is a very important part. I can see from both front and back. So there is no need of trochanteric osteotomy, and this approach is preserving the gluteus muscle. I'll show you the video. So this is anterior approach, very easy when there's a external rotation deformity. When there's a internal rotation deformity, posterior exposure is more easy. But in fused hip, this is excellent, right in front of you. Just go and resect the neck, you get mobility. So this is how I have shown from the lateral incision, standard posterior lateral incision, and you can go anteriorly, and this is anterior exposure. You can, under the capsule, you can put a spike medial to the hip joint as shown here. It is quite safe. Just dissect subperiosteally and safely you can put the spike. So entire fuse mass is there and the entire neck is exposed, and safe resection with the saw. You can take a sandwich cut. So front and back exposure, neck resection safe. And then start trimming, debulking the bone. Soft tissue balancing is a very important issue. Closure. Now, very important thing is, there is, with external rotation deformity, there is no capsular remnants for closure because you release everything. So what I do, some soft tissue scaffold by quadratus muscle, which is quite bulky, so it can be stretched over, and the cleavage of the exposure has to be closed. So some soft tissue scaffold is made to where the fibrous tissue forms and gives some support. If you don't close it, it rolls up and it is a cleavage for dislocation. So again, healthy gluteus medius, this is anterior exposure. So this is beautiful exposure. I've shown the slide. So fuse mass you can see on the lateral side. The trochanter, this is anterior exposure. So very safely you can dissect the neck. And entire gluteus muscle is completely saved and not affected, gluteus medius muscle. So this is a short video. This is the incision and I'm exposing anteriorly. So expose the neck and directly resect with the saw. Once you resect, you get mobility, and then you go in posteriorly, debulk, and you can see there's a ligamentum teres is always intact and there's some fat pad. So identification of the true acetabulum, these are the various landmark margins of neck resection, remnants of glenoid rim, transverse ligament, and remnants of ligamentum teres is always there. There is always some fat in pulvinar in, I would say, 100% cases. Then still you have a depth of the anterior wall. And if you want, it is not necessary. I have not used intraop X-ray, but any doubt, you are most welcome to use it. And Meko Robo gives additional benefit. That's a different issue. Now let's come to cup placement. First, normally I usually put cup first. So version and inclination is very important. And irrespective of the pelvic position, anatomical landmarks are very used. And that's very, very important. Now, version of the cup is best, it should be parallel to tal. The inferior margin of the cup should be parallel to tal, and inclination, if the inferior part of the cup is inside the tal, medial to tal, you can say the version inclination has to be 45 or less, depending on how inside it is. So it has to be for 45, it has to be just inside the tal. So that gives, these are my indications of, for inclination and version. Now, depending on this, now if you have a robo, you can get additional information. I use it now routinely, Meko Robo. There are few other guidelines for rimming. These are very important. McCollum's line. It's an imaginary line from the sciatic notch to anterior superior iliac spine. You draw an imaginary line, and rimming has to be perpendicular, right angle to it, or slightly anterior. So that gives a perfect inclination for the rimming. Now, single stage bilateral THA has got many advantages. Single anesthesia is better than two anesthesia. Rehabilitation is early because unless you operate both the hips, make both the hips mobile, it is not very safe to mobile if the other hip is deformed. So there are high chance of dislocation. So it is very important. You may delay mobilization, but safe mobilization is important to prevent dislocation. So it is better that do both the hips and then safe mobilization. Ambulation is better and safe. Hospital stay is also less, 40% less. Overall cost is also less. So deformed side is done first. You can see here the epidural is also there, and hip is abducted in almost 45-60 degree. And once you do that, then you can turn the patient. Let pelvis be in any position. You must understand the orientation of the pelvis and use the anatomical landmark that gives a better understanding. And clinical mobility and stability is the key factor in bony fused hip, because if you cannot do standing and sitting inclination X-ray, because here both hip is also fused and spine is also fused. So all the hip is going to change. Once you make the hip mobile, the hip angles are going to change. So it is very difficult or not reliable the thing for doing this pre-op X-ray of standing lateral and sitting lateral X-ray, because hip is fused, hip is going to change. Once you make the hip mobile, it is going to change the position of the spine also. So it's a very difficult issue. So there is no fixed point, and preoperative planning has no role unless there is a lot of kyphosis, or kyphosis is more common. So you can reduce the version. But most important, I advise you, intra-op, there should be good 90-degree range of arc of movement with stability, and front and back. It helps you to give a good impingement and check the stability of the cup. Heterotrophic ossification prevention is the most important. Washout of bone debris, avoid trochanteric osteotomy, soft tissue handling, avoid stripping. These are the standard things. Hematoma formation, avoid hematoma formation. Indomethacin or any anti-inflammatory, it works, gives for 6 days. There is one more thing, linear radiation, single dose, 700 centigrade within 48 hours after surgery. It kills the cells of the, so it has some risk also. And but I have not used it because Tata cancer people, they say there is a risk of cancer with the radiation, so they don't give it. So that's their reason. So though Tata cancer was in front of KM hospital, I never used it because they prevented us. But it is described in the literature. Personal experience, last 38 years, I've done about 252 total hips in 154 patients, 130 ankylosing spondylitis, 16 rheumatoid, 8 heel TB, and bilateral single stage was done in 58 patients. Bhosale's dual hip approach was used in 118 patients. Not every patient requires it. Whenever it is required, you can use it, especially when there is external rotation deformity. So I'll share some examples. Abduction external rotation is the most common deformity. Now you can see this patient, there's a zero moment, but they still walk. Every patient, bilateral fused hip, they drag themselves and somehow they walk, even with 0-degree movement. And this is 13-year post-op, that time cemented, depending on his cost and various factors. So our choice is cementless. And wind swipe deformity, one side adduction, one side abduction. So you can see here, it's like a roll, and it's just moving like a roll. Spine is fused, hips are fused. There is hardly any gap between both the knees, but they walk. Some dragging, everything. These are young people and these are challenging. So it's pleasure to make them mobile. And both hips are done and they are mobile. straightened completely. Bilateral abduction deformity, again, some unusual cases. You can see they walk like an abductor gait, zero movement, both the hips, young male, 24-year-old. And it is possible, I've used a lot of metal on metal that time. It was Zimmer, and luckily I have not come across a single case of metallosis with these patients. Young patient, 18-year-old, bilateral fusion, hardly able to walk, and 11 years post-op. Some patient, they can sit on the floor because of the probably large head, metal on metal, whatever I've used that time. Overall, their activity is very less compared to normal patients. Rheumatoid arthritis, bilateral fusion, you can see there's a flexion deformity, 26-year-old female, and both hips are done. And this is 17-year-old follow-up. You can see this was post-op, and this is after 17 years, metal on metal, and she's got 3 children. Everything is safe from North Place, and activity is also almost same after 17 years. Pelvic obliquity, this is an important issue. This was a case of spine, which was my colleagues corrected and fused, and there was a pelvic obliquity of 8 degree. On one side, there was a mobile hip, right was mobile, left was fused. It was a heel tuberculosis, and pelvic was tilted on the fused side. So there was an 8 degree of pelvic inclination. So this preoperative planning is very important, and you have to correct that. And this is how it is corrected. So put cup in 40 degree functional inclination. You have to put cup anatomical 48 degree. So that's a very important understanding. So functional, to make it 40, actually you have to put inclination of 48. So this is an important part of preoperative planning. And pseudokyphosis, because the same flexion, they walk like this, spine is straight, and it gets corrected. That's a beautiful, after 12 years, he's enjoying the mobility and walking. Sometimes knee is also ankylosed, like this patient, and because it was quite complex, we had to use LCCK, the varus valgus type of processes, constraint type, because we have to achieve the good stability. That's important part. Some bilateral neutral position in a policeman, and he just dragging like this, both hips are fused. And after 10 years, he's enjoying his mobility. Severe flexion deformity, and both it's got corrected and good mobility. So he used to come on wheelchair, now he's got bike, now recently married and he's got children. Again, some grotesque deformity, hip, and they young people, they drag like this, and really nice to see their mobility, and they get job, they do some good job. This is one 32-year-old follow-up, revision done after left 14 years, right 16 years, post revision 16 and 18 years. So 32-year-old follow-up. You can see this hip initially cemented, it was loosened, then I had to do ETO both the side, one at 16 years, one at 18 years, put a Wagner prosthesis, and this is 32-year-old follow-up. After ETO, the osteotomy, if you take care of the biomechanics, everything, biology, it unites very well. And you can see how he was at 10 years and now he's at 32 years. The bones are solid after revision. The ETO has joined and you can see the X-ray, 32-year-old follow-up. So results, HSS score improves from 40 to 89. Range of movement progressively improves, and complications, splintering of the calcar, dislocation in two. But usually the mobility is less, and this is very important that intra-op range of assessment is most important, and pre-op planning has limited role to understand because it's a quite complex situation. You cannot just feed because you don't get the correct information pre-operatively in fused spine and fused hip. So intraoperative judgment is the most important. Sometimes there's a stretch of the femoral nerve in one patient. Heterotrophic ossification rate is little high. Infection was 2. So it matches with most of there are multiple reports people are doing for ankylosing spondylitis. So conclusion, gluteal muscle function improves once mobility is achieved. Bhosale's dual hip approach is very useful for safe neck resection, avoid gluteus medius indication of true cup location restores biomechanics, cup version inclination, use anatomical acetabular landmarks. Cementless THA is excellent osteointegration. Single stage bilateral THA has many advantages, and large head gives a better mobility. It is not must to use dual mobility. Only thing is we have to wait for dual mobility. It is definitely newcomers should use dual mobility because dislocation is the main risk. But the longevity is a issue. I think things are improving, and it results of spontaneous ankylosing patients are better than arthrodesis. So it's highly demanding and highly rewarding. Thank you very much. Hello? Hello?
Can you see any questions anywhere?
Yeah. So I hope my voice was there because...
Pradeep,
Yeah.
this was an excellent lecture. We've heard it before, but every time I hear it, I feel sort of rejuvenated.
This is to my heart because I've done a lot of research on this. I have also published in the textbook also. And I mean, it's my pleasure. I worked very relentlessly on the anatomy and this exposure. And I'm enjoying any fuse it comes, I enjoy to operate.
Pradeep, can you see the questions on your chat box?
1 second. If somebody can talk, I'll be busy because...
So shall I tell you the question?
Yeah, please. That will be wonderful.
So does cement on cement makes more sense for previously done cemented THR or not?
See, as a standard thing, cement should be removed because if you remove cement, do a proper job, do ETO, remove cement, and it has got a fantastic. I showed you 32-year-old follow-up overall.
Okay.
So that was a cemented. Initially, my accessibility was for cemented, but now cementless has really taken up a good, I think, biology, and things are improved. So one more thing is with cementless, you have a chance of using a bigger head, which is not possible with cemented. That's a plus point.
Yeah. Okay, my other question to you, Pradeep, is, can you hear me?
Yes.
If it's in a rheumatoid cases, suppose you have a hip and knee, both problems, how would you address first?
Always there's a standard dictum, proximal should be done first. That's a standard thing, but many times I have done both together also. And you have to take a call depending on the deformities because it can change to some patients. In some patients, 1 or 2 I have done knee also first, but usually because your axis starts from proximal to distal, proximal should be done first, hip should be done first, because otherwise it becomes very difficult to do
So in continuation of that previous question, is there a role of a cemented THR in today's your practice?
See, my practice, I will tell you the standard. If you do a good cement, it has a definitely role, and all over the world they have shown cemented does do well, provided all the techniques are used, proper cementation. That technique is the most uh, required. If you use a perfect cement technique, it works very well.
Right. There is another question that do you do adductor tenotomy in a fixed deformity before you start the surgery?
Because there's no mobility, so adductor tenotomy may not have direct role. Once you give a mobility and you understand the deformity, because many patients are abducted, so there you don't expect adductor deformity. So only after mobility you will come to know what things are tight. Many times abductors are tight, capsule, everything. So depending on that, you can release it. But since fuse hip, it is very difficult to do preoperatively. Unlike other case, you can do it has some additional benefit. If there's a hip is mobile and there's a severe adduction deformity, tenotomy, if you do early, you get a better chance intraoperatively for balancing.
Right. You said that the dual mobility is questionable. Overall, in ankylosing spondylitis, the dislocation rate, have you seen less than the normal?
My a very important point is the position of the anatomical landmark and slight variation up to maximum 10 to 20 degree of change of position, because pelvic tilt can change up to 20 degree, all the spinopelvic issues. When you set 90-degree position, then the pelvis contribution is 20 degree, hip contribution is 70 degree. So there is a 20 degree of pelvic tilt maximum. So that contributes to the acetabular version. But if you do carefully intraoperatively, I think that's the most important key part. So large diameter has role, capsular closure has role, and your combined antiversion and all those factors are very important.
There is another question. What implants are preferred? 127 degree, 132 degree femur stem. Which one will be preferred in such cases, or would you keep options ready for the femoral offset?
Usually, two options are available: high offset and standard offset. And I'll prefer modular, because modularity is very important intraoperatively rather than fix. I know fix has a better longevity and other less issues, but modularity gives a better, definitely it helps you intraoperatively, and sometimes you may require high offset.
Okay. Right. Fine.
So can I say something, Dipak? Great talk, Pradeep. I think it was a pleasure listening to that. Like you said, results are so good. It's such a joy to do these surgeries. So the only one comment I had was with cemented, sometimes when you end up doing it, using a large head, there's no data to say whether a cemented stem will take a large head. I think that's
No. In fact, I said cemented, you cannot use a large head.
No, I know that. I know what you said.
Yeah.
I'm saying we don't know whether a cement mantle will hold against a large head forces. I think that's one study which is waiting to be done. If
Yes.
we don't know whether if you use a large head, the cement bone interface or will go wrong or something like that. So if that confidence is there, then using a large head with cemented also is a great option. Only thing is biomechanically will hold the test of the time is something which will have to. Which I don't think there's a study done.
Very important point is with large head, the poly size becomes small.
Yeah, agreed. Yeah, it really depends on the size of the socket as well.
Socket has to be that big to use at least thicker poly. That is the main issue. That's why a large head is not available for poly.
Yeah.
Minted for.
Yeah. We take one more last question, Pradeep. It's there on the chat box. It says
Sure.
that in the entry approach, do you preserve the gluteus medius or 80% is preserved?
100%.
100% is preserved. Okay.
I'll tell you, it fans out completely anteriorly. So I put a spike under the gluteus and retract it superiorly and expose the capsule. With external rotation, it is like a directly facing the capsule, everything in front of you. You just retract it, you want only for neck resection. Once you cut the capsule, put spike under the capsule over the neck and inferiorly. So that neck is exposed and you just cut the neck.
Okay, I think we are approaching 7:45. Let me just check any more questions there. No more questions. So people can send the questions and we will request Dr. Pradeep if there's any questions to answer. So Pradeep, on behalf of Dr. Vikram Bhai, the Managing Trustee, the President, Dr. Indrajit Sardar, my colleague, Dr. Dhanasekara, Dr. Pachore sir, and all other colleagues and executive board, we thank you for sparing your time and delivering a wonderful lecture. So have a good evening. Happy Vijayadashmi to you.
Yeah, my relatives are waiting. So can I leave?
Yes, no problem.
Okay.
Fine.
Thank you very much.
Thank you. We request Dr. Sharan Patil to share the screen. Meanwhile, let me have a couple of things to announce. The next month's lecture is going to be on the 16th of November. 16th of November. And similarly, like every time, we will have two eminent speakers, one for the hip and one for the knee. This second speaker for this today's talk is none other than our past president of the Indian Society for Hip and Knee Surgeon, Dr. Sharan Patil, a very senior faculty member, a teacher, a mentor for many young surgeons, and is the chief orthopedic surgeon for the Spurs group of hospitals based in Bangalore. And it's our privilege and honor to have Sharan here on this academic program. See, the good thing, all the friends and colleagues, these senior people go to their places to learn and teach. And here they are coming on our request. Okay. So we should thank all of them. People are actually doing fellowship under them and going there to teach, learn. So it's always a great pleasure to have the very senior faculties here to come on this teaching platform. And with these words, wishing you happy Vijayadashmi, Sharan, on behalf of Indrajit, Dhanasekara, and myself and Vikram Bhai. Please share your screen and welcome.
Can you see the screen, Dipak?
Yes,
we can see your screen.
Great. Yeah. Firstly, thank you so much for this opportunity to share the evening with all the young people. And certainly, you don't have to thank me, Dipak. We are in the same fraternity and family. You guys do so much of putting this together and getting everybody together. All of us thank you for doing this so religiously, Dhanasekara, you and the entire Ishks team. It's amazing, you people, how much of energy you spend on this. Is such a dedication to teaching. So my brief today is to talk about the principles of revision TKR. So I know the people on the group who are listening to this are young orthoplasty surgeons. So I have tried to keep it as basic and as straightforward as possible. I'm very happy to take questions and dwell into anything which looks a little complicated to understand or anything. So let's get started. So the principles of knee replacement remain exactly the same, right? So what is the principle? When somebody has arthritis, somebody has got disabling pain and mobility issues, you want to give them a knee replacement which is stable, which is mobile and pain-free. I'm sure all of you agree with that. And the very important fourth element is you want this to last as long as possible. So let's keep reminding ourselves, this is our aim. And this principle of giving a stable, mobile, pain-free, and a good longevity will remain the same even in a revision knee replacement. The issue is, can we do exactly the same like in a primary? A revision will last as long as a primary does. That is always a little compromise, and we'll talk about it as we go along. There are some things which are compromised in revision, which you don't have to do it in a primary. So again, just extending this further, like in a primary, you want to have correct alignment. Now, dwelling on this alignment philosophy, there are all this kinematic alignment and adjusted mechanical and reverse kinematic and all these alignment philosophies which have come into play of late with improved and precise ability to place the implants. These alignment philosophies are generally kept out of the way when you're doing a revision. When you're doing a revision, you're simply looking at traditional mechanical alignment to bring everything into play, because the implants, what you're going to use here, may not be able to withstand any forces away from anatomical alignment. In a primary, that's being challenged and we adapt different alignments. But in a revision, we want a correct mechanical alignment so that the forces go through appropriately, and this whole construct will last for a longer time, because a primary is almost resurfacing, but when you do a revision, you're using so many other things like stem extensions and sleeves. All this will compel you and push you to go along a situation of mechanical alignment. There are compulsions to do that, and it's also desirable to go that way, and that's the only way as of today's science, that's what we do. Second most important thing is you want to preserve the bone stock and replace the bone defects. Two things I am saying now. One is you have to preserve the bone stock. How do you preserve the bone stock? We will talk about it as we go along. And replacing bone defects. These are very important. And there are strategies to do this. When we do this correctly, you will be able to achieve a very good construct which will serve the purpose of a revision surgery, which will give pain, which is balanced, gives pain-free mobility, and it will last long. Soft tissue balancing can never be ignored. Soft tissue balancing is still the most important thing, even in a revision situation, unless you up the constraint. And we'll talk about that as well. And last but a reasonably important thing is to maintain the joint line. It is challenging to maintain the joint line sometimes in revision, but today there are many strategies in which we can achieve and keep the joint line where it really belongs to, which gives us the best possible patellofemoral and even mid-flexion stability when we maintain the joint line at appropriate place. Let me say 10 steps of planning a revision joint. So let me go through all of this and we'll deal with each one of them. It's like the 10 commandments. How do you do a replacement? First thing is you need to assess why this primary has failed. I'm sure all of you agree. It could be infection, it could be periprosthetic fracture, it could be aseptic loosening, it could be so many reasons, the polywear, whatever it is. One needs to know why it has failed, and because what we do after we know why it has failed is different in each situation. Obviously, with infection, your strategy will differ. You'll do a two-stage. If it is because of a periprosthetic fracture, you've got different compulsions why you're revising. While it's an aseptic loosening, you want to assess what went wrong. And if somebody's knee is getting replaced with none of these, maybe there's an alignment problem. That's why they don't have a range of movement, or it's become painful and it has failed. Then again, you need to know where the malalignment is. I'm sure this forms the very basic step the first time somebody comes back to you after knee replacement, whether it is after a few months, few years or after a few decades, that's how you look at it. Why did it fail? Second thing is the clinical workup. We all need to have a very organized chart how we do a clinical workup. And that clinical workup also points us towards why this failed. If there is infection, if there is any general medical situation in that person, we cannot be focused only as orthopedic surgeons. We need to know what is their nutritional status, what is their psychological status, and each one of the aspects contribute when we are doing this revision joint replacements. Of course, good radiological views, plain x-rays give a hell of a lot of information, but CT scans, sometimes metal suppressing MRI scans are all very, very useful to point us in the perfect direction how we need to do this. The next point is implant evaluation. What company implants were used, what kind of implants were used are very, very critical. And these implants last long. Some of them have come and gone. You need to know what it is. And I think what Ishks has done, the entire gallery of the implants, what is kept in Ahmedabad, is greatly useful to know the history of these implants. So each one have a different strategy. How do we remove? Sometimes we do a revision joint with partial revision. We don't have to touch the tibial component, we don't need the femoral component. But how do these match is very important. I cannot emphasize how important is soft tissue status. If there are any sinuses or multiple incisions, how do you deal with that? Component removal determines what kind of implants you use, because you want to protect your bone as far as possible while removing it. And bone stock restoration. One cannot assess the bone stock adequately with imaging. Quite often, we get an approximate idea. When you really open up and remove the implants, that's when you know. So one needs to be prepared much more than what the X-rays offer in terms of what strategy you'll adopt to restore the bone stock or use implants which can make good when the bone stock is very low. Of course, component selection, what kind of constraint you use. And I think that's a basic philosophy. Like in primary, the more constraint you use, the joint is less likely to last long. So the least constraint, but a stable knee is what you're aiming at. So you have to get this statement correct. I will use the least amount of constraint to give a very stable joint replacement. That is a diktat. So, but does not mean you will not up the constraints. You will up the constraints because paramount is stability. And then if you have to go a hinge, you have to up the constraints completely. You still do it because primary reason why you're doing the joint is to give stability. Of course, we want it to last long. And finally, and more importantly, is also implant fixation. How do you fix? You have zone 1, zone 2, and zone 3. You need at least 2 zones of fixation. And sometimes the epiphyseal area where the plate sits, the tibial plate or the femoral component sticks to the bone is not a very smart area with a lot of bone loss. Then you use metaphyseal fixation, and then sometimes use diaphyseal fixation as an augmentation. So how do you do this? So your implant selection is also a very important part of the story. And of course, post-operative management is part of any of our surgical acts we do. So I have just given you a bird's eye view of what are the 10 steps and how do you meticulously follow it. So I also mentioned in that slide, infection, aseptic loosening, wear, osteolysis, and you do sometimes do revision for arthrofibrosis, rather when the movements are completely restricted and patients are very unhappy. I'm not sure arthrofibrosis is a very well understood entity. When we have not great mobility in the knee, one needs to think of component malpositioning as a possible cause for this, because arthrofibrosis does not have a way of have a diagnostic test to say this is what is arthrofibrosis. One needs to be careful. You need to be sure that changing the implant and redoing it is going to improve the mobility and give that whole comfort to the patient. Psychological profiling is also very important. Of course, implant failure, periprosthetic fractures, these are more obvious reasons of failure which you can quite obviously see and address them as you go along. Now, clinical evaluation, how do you do this? I said you have your protocols. How do you go about doing it? Don't skip any step. Don't go by gut instinct. You have to do your blood parameters. You have to, sometimes you do bone scans, sometimes you do CTs and MRs, but very important to do a thorough evaluation. What is the CRP? What is the ESR? You sometimes aspirate the knees. If there is suspicion of infection, you have got multiple ways of culturing, extended cultures. It's very important to go through your algorithms to establish that. And also, next step, obviously, once you know that you're not dealing with any systemic things or infection, then you go and test your ligamentous status. Please understand, sometimes bone loss, where the medial side of the tibia is completely collapsed, then again you feel a false sense of ligamentous instability. One needs to be sure that is there a loss of or a stretching out of the ligaments, the medial collateral, lateral collateral is the main thing I'm talking about. And if there is that, and one needs to be prepared while you're doing the surgery to use more constraints, so all your implants and everything needs to be there. If there's a deformity, obviously one should never miss extra-articular deformity, previous fractures or maybe stress fractures, maybe traumatic injuries in the past. One should never miss any deformity because of that. Also the deformity which is caused because of loosening or asepsis or periprosthetic fracture, that needs to be, or a malunited fracture, that those needs to be answered. It's very important. The knee replacement will function well only if you have the quadriceps in place. I'm sure all of you agree that the extensor mechanism is an extremely tough fellow to deal with. If your extensor mechanism is disrupted or it is not functional for whatever reason, sometimes a very long-standing unused knee or the quadriceps with multiple surgeries, or if the quadriceps is given way for some reason, then doing a revision joint replacement surgery in those situations will not get you the desired results. It might take away the pain, but it will not be able to give you the result of a good extensor, and repairing that is not necessarily a great equation, especially in revision surgeries, even though there are ways of doing it, but it's not something you'd be too excited about. You should look at an option of fusing the knee if that's what it needs, but be very, very aware of quadriceps status. When sometimes the knee is very stiff, you're unable to assess the quadriceps status. A good ultrasound examination of the quadriceps or an MRI scan will give you some idea of the quadriceps, even if it is wasted, whether it's intact, whether it is there or not. And never ignore the general health of the patient, because you're treating just not the knee, but overall the patient. If his age and his general health does not have too much of a bandwidth to take your major surgical procedure, or his lifestyle does not require one, just for the sake of doing it is not the reason to do it. And lastly, but most importantly, some of these people are highly drained. If you're doing the surgery first time, second time, and third time for revision, these people are mentally exhausted, and they are not ready to fight with you to achieve the best results. And financial constraints are also a major issue, and they do affect the families and all of that. Those things are very important considerations when you take the decision. Like I said, radiological evaluation, this is a simple X-ray which will show you typically what it is. And if you look at this, Of course, you will say the most possible reason is there is some aseptic loosening, and that's why this could have failed. It's good to know what implants these are and what kind of bone loss there is, and is there ligaments which are damaged, and that give you a reasonable idea of how to look at this and where the failure has happened. And of course, you never take away your mind from infection, because one needs to rule out infection in every case, whether you suspect it radiologically or not. A CT scan is of great importance. Sometimes they don't have great range of movements, and they are completely pushing you to the wall and say, we don't have great range of movements, and you are pushed to the wall to do a revision. And arthrofibrosis is an easy tag to give. But if you look at the positioning of the femoral component, sometimes if it's not well positioned, that itself could be the reason. And when you are revising it, if you are aware of that, you will not make the same mistakes. And getting the rotation right today with technology is much more easier and much more accurate. But conventionally, there are many ways of getting the rotations right as well. Osteolytic zones, there are lots of classifications to know this, and all these classifications help you from for those of you who are doing FNB, the exam point of view, but also it gives you an idea and a strategy how to deal with this. And again, the zones and which zones are loose on the femoral side. I showed you the tibia, and this is the femoral side. And when you know this, your strategy completely, you are well prepared to do a revision when you are assessing this well. Like I said, whatever are the implants which are there, which need to be removed, you should know what implants they are. Whether it's a CR, it's a PS, and which company, what are the implants which have pegs, what are the implants which have, which kind of stems they have, and how easy or how difficult it is. Sometimes specific extraction things you need in the OR to remove them very effectively. Of course, it's much more relevant in a hip situation, but in a knee situation also, one needs to be very careful, because like I keep saying, how smartly you remove the implant is what matters. And if you are doing a partial revision for something where there's a need for revise pretty immediately before the implants have suffered any insult, then again, you need to know what femoral component matches with which tibial component, and what poly works, what poly is put in between. These are all very important to do an implant evaluation. I did talk about soft tissue status. Obviously, if it is infection and if the sinuses, it is a totally different ball game, and one needs to get these to heal even before we look at a revision by doing a two-stage. But if it is not, and if it is, if you're getting a patient who has been multiply operated, and if it is an old person, invariably vascularity is compromised to some extent, and one needs to have a clear strategy. We all know the blood flow comes from lateral to medial in the knee. So using the lateralmost incision as a general principle works very well. And these scars are sometimes years old, so they won't bother you too much. More often than not, if you just use the lateralmost incision, you will do well. If any doubt, please involve a plastic surgeon. He always have a plastic surgeon friend who will help you out with dissection and closure. So he knows the anatomy better. He has got multiple other strategies how to do this. Sometimes when we are really pushed to the wall, they turn a flap and graft it and increase the vascularity of the area as well. And those are very important soft tissue envelopes to have for the best possible outcomes. Let's talk about approaches now. There are a few skill sets one needs to have when you're doing revision. And I keep saying how to use some of the implants and surgical skill sets. And two of these skill sets are about approaches. Your standard medial parapatellar approach will do the job more often than not. And what's very important in a revision situation is you do your medial parapatellar approach, but you need to adequately create the gutters on both sides. That creating the gutters gives you a great exposure, and you spend your time doing that very meticulously. If you're don't have a good range of movements, an extensile approach will be of great value. When you're doing an extensile approach, what do I mean by extensile approach? The same medial parapatellar approach can be extended to make it an extensile approch. Quadriceps snip is probably the most commonly used strategy. And I think the next slide of mine will show you this. You can see on this slide a classical medial parapatellar approach. And if you look at the top of the slide, you have a little deviation of your incision going towards the medial side, rather the lateral side. When you do that, the whole patella can be shifted off effectively. And this quadriceps snip works wonderfully well. And when you close it up, the quadriceps function is not compromised. Sometimes even that, but you can't use all strategies together. One needs to know what you're familiar with, and you have to go with one of them, not necessarily, or you cannot use two strategies together that invariably cause damage, and you can see why. Sometimes you think this quadriceps snip is not going to give me the exposure, and you want to see the entire joint right in front of you. You can do a quadriceps turn down. Go up to the suprapatellar area and make an incision like you can see in this picture, an incision which will rip open the quadriceps, and you can turn it down and the joint is in front of you. I should confess that this is not a great strategy because it leaves you with a lot of quadriceps lag and a challenge later on to deal with. I can't remember the last time I did this because by and large a quadriceps snip works very well. But there's one other strategy which I prefer over a turn down, is to do a tibial tubercle osteotomy. And that's how it is done. It's an extremely well documented way of doing it. The way you do it is you need to make your drill holes, make a slightly longish one with the tibial tubercle, with the quadriceps, with the patellar tendon attachment. You make a drill hole on the side and smartly lever it up with periosteum intact on the other side, and then you have the entire extensor mechanism flip laterally, which gives you a great exposure. This I have done many times, and I have no regrets of doing it because it seems to heal beautifully. This technique is something one needs to watch on the video. It's not difficult, and it's easily doable, and you can fix it back either with wires or with screws which miss the stem, and more often than not, in a revision, you're using a stem. Disadvantage of union, and this is very theoretical. If you do it correctly and maintaining the vascularity of this piece, I have not had an occasion to see a non-union, or I had to do something about this. So you can be pretty good at this, and this will give you a great armamentarium to do your exposure. Right. Now, like I said, you need to have a strategy. How do you remove the implants? If it is aseptic loosening, by and large, it comes out very easily. What one needs to understand is the idea of this whole slide of good component removal is to preserve the bone, because bone is my friend and I want to preserve it. You want to remove the implant with the cement with the least amount of bone loss. Having said that, sometimes it's inevitable because the bone can be very osteoporotic. You can lose some amount of bone when you're removing it, and that really determines how what implants you'll use to give a stable construct later on. And the next important thing, what I keep thinking about when you're when you're removing the implants is the less bone loss, the better the quality of your revision. It's worth being very deliberate about it, very slow about it, very meticulous about it, and have all these giggly saw, burrs, and cement removal instruments to be able to do this effectively. Let me show you this is one of the things which works well for me, and you can use a giggly saw, and it neatly takes away up to the box. You can very nicely take away the interface between the cement and the bone, so the implant and the cement come out together. Quite often when you do that, you are able to go right up to the box, and then you can use your osteotomes. And what you can see on the other side, so when you go right up to there, it pretty much pops out. Anyway, so the other method of the tibial implant removal, very classically described as stacking of the osteotomes. This works very well because the moment you try to liver with an osteotome, an osteoporotic bone, it will invariably sink the platform, and that's bad news for us when we are doing a revision. So we need the stacked way of putting the osteotomes nicely lifts it up and does not depress the osteoporotic bone. That gives you an excellent way of removing it. And I'm telling you, with experience, you will realize that it is such a crucial and important step for the primary surgeon or the surgeon, not the assistant, to do this. And you have to be very responsible while doing this. Yeah, the other important thing is you'll end up spending a lot of money using augments and sleeves and all of that if you do this part of the story badly. Okay, now what is the strategy you use to do this? Once you've removed all of that, I'm not going to go into great depth of this, but I will tell you a general principle of how do we go about doing. You obviously need to up your constraints the moment you've lost some bone, and invariably in a revision situation, more often than not, you've lost some bone. And you also need to know the strategy of balancing. The flexion extension gaps can be quite challenging, and there are many ways of getting these right, but the most important step for me is use tibia as you're referencing. Do the tibia first, whatever kind of surgeon you are, femur first or tibia first. In a revision situation, doing the tibia first gives you a great platform on which you base your entire construct of revision. Once you are stably putting the tibial plate there or the tibial construct there, you can use that to get your rotations right, to get your gaps right, and that's how you make everything work. And I'm sure all of you are familiar with the revision. You can go from CR to PS to in TC3 or CCK to constraint, and whatever it is required, how do you go about doing that? Like I said, if you're in a situation where there's a lot of bone loss and you are able to construct the tibia, you sometimes use metaphyseal sleeves. These metaphyseal sleeves are a wonderful gift to an orthoplastic surgeon, and I love using them, either the cones or the sleeves. I use only the sleeves. I've never used cones. And this gives you an opportunity to place the tibial platform proud of the tibia, what is left, because the construct gives you stability in the metaphyseal area, and the epiphyseal area can be filled with bone cement. So the joint line restoration happens beautifully with this because you can project it up. And how do you assess the joint line? Of course, you can use fibula, or you can use the epicondyles, lateral epicondyle, to see where it should be. We've got different measurements and try and get this right. So if you're using a metaphyseal sleeve, it can give you the size of the sleeve which you can use to make the tibia proud, and that becomes a stable construct. And from there, you go to the next steps. Once you can see in this picture, the tibia is proud, it is sitting up. And when the tibia is sitting up and it is stable, and you're reasonably done with that. Of course, you can use distal femoral augments. Invariably, there's a need to do that. And when you have bone loss and you're using a knee which is like a semi-constrained knee, you should be able to match the anteroposterior diameter, and you invariably have to use the drop-down bolts so that your implant sits flush in the anterior surface of the femur, and that is the way you do the entire construct. Here you can see the tibial metaphyseal sleeve with a stem extension as a construct. On the femoral side, it's just a stem extension. And once you get these very well rehearsed steps right, because there's no point in me telling them, because when you're doing it, you go through each of these steps effectively and you get the best possible construct on. Bone stock restoration, the strategy here, like I said, preoperatively, you need to have an assessment of what the bone loss could be, but more importantly, you need to have augments, metaphyseal sleeves, cones, allografts, any of these which are fortunately available in our country, pretty much across the country, and these are very important to be there for your armamentarium to get the best possible outcomes. Allografts these days, we don't tend to use in primary knees when you have bone loss. Allografts are very effective, but in revisions, it's less and less, because these beautiful stuff what are available have taken away the need to use allografts more often than not. I made a statement when we started saying that the whole idea of a knee replacement surgery is, I'm never bored of repeating this, you want to give them pain-free, mobile, stable joint which will last long. And out of this, how do we achieve this? How do we do this? Is on the table. We have to achieve all of this except the longevity, and that longevity is by and large determining the amount of constraint we use. The least constrained implant what we use is a CR knee, and CR and PS pretty much have the same kind of longevity. As we increase the constraints, invariably the longevity gets compromised, because there is inherently the bone implant interface take a lot of strain, and invariably when we are using increasing constraint these days, we use mobile bearing platforms, which takes away the stresses between the implant bone interface, and that helps. But still, one needs to be cognizant of the fact to use least amount of constraints without compromising the stability. Of course, hinge is the ultimate constraint, and when we use a hinge, when we have loss of ligamental stability, when your substitute, your MCL is not functioning or LCL is too bad, then invariably you'll end up using a hinge knee, which has got the maximum constraint and least amount of longevity. So these are the ways to fix the implant. Like I said, 2 zones you need to fix, and implant fixation, obviously, when there's the least amount of bone loss, you have simple things like cement and screws. But when there is, you want a bit more stability, do a wonderful job. But if you have a need when part of it's not a very well contained defect, and these metaphyseal sleeves do a wonderful job. They also give you a prop to up your joint line in many ways to make the size of your insert size smaller. It's a good way. You don't want to use an insert which is more than 20 at most. So if you up your tibial platform, it gives you a very good way of decreasing your size of the insert. Metaphyseal sleeves are great friends for us to do. If you're cementing whether you're doing a hinge knee or wherever you have to use cementing, please do respect the cementing process and the technique like you do in a hip, and you need to use guns if required, and you need to use cement stoppers so that you get good kind of a cement mantle all around your implants, and never ignore those steps, and don't take it lightly while you're doing cementing. It's very important. And last but very important is the protocols you have to follow. You've got great guidelines if you're doing a second stage revision for sepsis or single stage revision for septic knees, then antibiotic follow-up, soft tissue integrity is super important, and you need more follow-ups than otherwise. And rehabilitation, obviously, as a surgeon, you know if your quadriceps status, how it is, your tibial tubercle osteotomy, how it is, and whatever you see on the table that needs to be effectively conveyed so that we get the best post-operative protocol without compromising on the outcome. And being slow is not a shame. We don't have to create world record. What's important is what the patient remembers 10 years down the line. The principles of revision, again, to repeat: correct alignment, preserve bone stock, replace the bone defects. Soft tissue balancing is still the key, and this is important till you go to the point where flexion extension gaps you just cannot match, and your collateral instability is too bad, then invariably you go to a hinge knee where the soft tissue balancing does not play a great role, and try your best to reconstruct the joint line, which will always hold you in good stead. And I thank all of you for listening, and I'm very happy to answer any questions if you have.
Thank you, Sharan.
Yeah.
Excellent, extensive talk on the revision principles. Dr. Indrajit, any questions or any comment from you?
The comment is one thing where the key thing is, when do you think of a revision knee and when do you think of an arthrodesis?
I think great point, Indrajit. So I think I touched upon that. As orthoplasty surgeons, sometimes we tend to be gungoistic and think, we've got these many implants, these many ways of doing it. Give me anything, I will do it. That's all okay, but that's very academic. One needs to know when to give up. And I think a good surgeon is the one who knows when to give up on his and not go by his ego and accept a compromise. If it is a re-revision, and if the infection is not coming under control, the bug you're not able to control it, and you can do the first one and second one, but at some point of time you need to say, I don't think I'll succeed with this, and we have to give an option of a revision in that situation quite early. And we've got fabulous implants today to do a fusion even in the presence of some infection. So that's one area. And the second important reason to do a fusion is when your extensor mechanism is badly damaged, and when you don't have a great hope of restoring extensor mechanism, that's another area one needs to entertain the need for doing a fusion. The psychological profiling, the financial status, the amount of chances you take by doing this, and the family's confidence or ability to endure through a possible reinfection. All these are factors which will push you to do a fusion, and one should not be ashamed to do a fusion and not necessarily push the patients all the way.
Yeah. Dr. Indrajit, Dr. Sharan, you already answered, but there is already a question which Dr. Indrajit just asked.
Yeah.
I think you already answered that. In case of infection gram negative,
yes,
plus discharging sinus, plus deficit patella tendon,
yes,
is it advisable to go for two-stage revision, or in older patient better is to go for arthrodesis? I think Dr. Sharan Patil has already summarized very well that in case of a bug gram negative and extensor mechanism deficit, all people, he has already said the arthrodesis is a good option.
Yeah.
So that was a question there in the gallery.
Yeah, Dipak, one more important thing is in India, if you look at it, we have more gram-negative sepsis of the joints than anywhere else in the world. So one needs to be aware of this. Gram-negative seems to be more than gram-positive in our situation for some reason, and we need to have strategies to deal with it. Of course, they are much more difficult to deal, and like Indrajit said,
Before we take another question, I would just want to ask you, any situation where you think the proximal and the distal, the quadriceps snip and tibial tuberous osteotomy, you said you are quite fond of doing. Do you think that you might have to combine both, or any one will usually solve the problem?
More often than not, I would say 90% of the time, or even more than that, a quadriceps snip with a fine dissection of the gutters and flipping the patella over, except you have a situation where the patella is very low lying, you have a patella baha situation, then a quadriceps snip might not work. Combining a quadriceps snip with the tibial tubercle osteotomy, I'm perfectly okay with in extreme situation, but not a turn down. Once you do a turn down, you have no choice of doing a tibial tubercle osteotomy. Obviously, you won't require, but I should say a turn down is not a great option. In my opinion, one should not go the turn down option.
There is a question on the somebody. Can you see the questions, Sharan, yourself?
Yeah, let me see where the questions are. Yeah, I can see the questions.
I think the last question is something about the type of implant for the arthrodesis you just mentioned.
Yes, yeah. So I cannot see the. Yeah, 1 second. Yeah, let me answer that question. You have got some beautiful implants now. The traditional one obviously is a Chanley kind of thing or an Ilizarov kind of thing to fuse it. But I've long forgotten to use that because we do cam titanium nails. Silver nitrate coated nails work wonderfully well. They're expensive, but what you do is you use a stem into the femur, stem into the tibia, and you have a fabulous locking bolt, which locks at the level of the joint line, and it gives you fabulous stability. And one good part of this cam titanium nail is you don't worry about bringing the two ends of the bone together. You're quite happy to accept a large gap between the distal femur and the proximal tibia. And I've got a huge series on this, and it throws up very good bone, and a few years down the line you'll see it's become one mass, and it's so strong you don't worry about anything. You allow them weight bearing on day one. Of course, it's proposed that this can be used in the presence of heavy infection, but I've not had the courage to use it when there is pus pouring, and invariably I do it as a 2-stage. But whatever little infection is there, it's silver nitrate coated and supposed to chase away the infection. And I've not had an infected fused cam titanium nail so far. But obviously, I've been a little bit of a coward to do it as a 2nd stage only, and not in the primary as a 1st stage fusion in infection.
Sharan, another question. I think we are just approaching 1-2 minutes left now.
Yeah.
So, with the sleeve, should we always use the stem?
Yeah, a good question. It's not necessary. It's not necessary to use the stem. The stem works more like a guide. Sometimes where you have a situation where it's not completely aligned, and in that situation I've used only the sleeve without the stem, and it's pretty effective, and there's no reason, there's no compulsion to use a stem with a sleeve. So you get a very good metaphyseal fix, and that gives you a good platform that's good enough for stability.
Right. Dr. Indrajit, anything else you want to add?
No, I think it's been a wonderful overall view lecture, which will give great benefit to a number of people.
Yeah. So, I think with this, we are almost closing the time, 8:30. Sharan, once again, on behalf of Dr. Indrajit, Dr. Vikram, myself, my colleague, Dr. Dhanasekara, Dr. Pachore, Dr. Leo, and all other executive board members, we thank you for sparing time and giving an excellent lecture. My gentle reminder to all the colleagues, those who have joined today, please spread the message. These are wonderful speakers coming and giving. The next talk is 16th of November. Usually we do it on Saturday. The time remains the same, 7 to 8:30. The format remains the same. There is one talk on the hip, one talk on the knee. So 16th November is the next lecture. And please request everyone, those who are not, be member of Ishks, try to come do some joint registry contribution whatever way you can. The Ishks joint registry also appeals you to contribute whatever best way you can. So on behalf of everybody, Sharan, we thank you. and we say goodbye and thank you to everybody. Dr. Indrajit, thanks for remaining present as usual all the time. And good night to everyone. Thank you. Thank you very much.
Good night, sir. We appreciate your passion for teaching. Thank you so much.
Okay. Thank you.
Thank you. Thank you.